So this is the second of the conversations we've had with some senior NHS managers about what research means to you and how we can do more to promote research for managers and their organisations. So, Candy, thank you for joining us.
Pleasure.
And perhaps you'd start by telling us a little bit about yourself and how you've used research both in your current life and through your sort of journey as an NHS manager.
Okay. Well, if I take you right back, my degree was in biochemistry. So obviously, much of my learning and work and development right from university was based on research. And in the fourth year of my degree programme, amongst other things, you actually have to undertake a research dissertation, and I did mine on, at that stage it was called respiratory distress syndrome in young babies,
Right.
working at the Radcliffe Infirmary in Oxford. And that just really got me into the health service, really, I suppose, and the importance of research, the spirit of inquiry, finding things out. But I also knew that I wanted to go into making things happen, and so there was a sort of natural segue into the National Management Training Scheme. I've been lucky enough to have been an NHS Chief Executive for 19 years. 8 years or so as Chief Exec of a two-site DGH, mainly acute services, but also maternity and community and so on. And then the last 10 years as a Strategic Health Authority Chief Executive. So that's really given me the opportunity, the privilege really, of being able to apply some of my learning as well as my experience into practice. And you have to combine what you know is the rational and sort of the evidence base in terms of know-how and so on, with your sort of influencing skills and your emotional intelligence around engagement, not just of staff, but of, if I think of the SHA Chief Executive, of your colleagues who are Chief Executives in their own right, and members of the public, of industry, of local government, and so on. So the sort of skills that you learn and the evidence base around leadership qualities is critically important in that, because you can't make things happen just by wishing that they would.
Beverly Alamo Metcalf, but her work and the work of people like Michael West, I think, provides some really hard evidence that a sort of an engaged workforce and a kind of values-led organisation can really demonstrably help performance.
Yes, and I mean there is definitely evidence around that, and for some years I think there's been evidence of the importance of clinical engagement, as one would expect. But sometimes one feels that sort of non-clinical staff get overlooked, backroom staff, administration staff, portering and housekeeping staff. If Aidan Halligan were here, Director of Safety and sort of, courageous man, great in terms of clinical leadership, he would say that some of the most important leaders and people who have supported patient experience and clinical outcomes have been the housekeeper in A&E, who helps sort of people who are in distress and gives them a calming cup of tea and so on. So the importance of seeing engagement in the round, I think is absolutely critical. And as you say,
that's interesting, isn't it? Because I mean, partly because I like the stories, but I have found very interesting the sort of observational research. I mean, there's some work that Justine Schneider in Nottingham has done on dementia wards, where researchers actually worked as healthcare assistants, and that kind of immersive research really told you something around. I mean, one of her key points was that these healthcare assistants, what she called sort of manage the emotional climate of the wards, and that patients and their families, particularly perhaps patients with dementia and challenging behaviour, related much more to the healthcare assistants than to the qualified nursing staff. So I think there's some really interesting, there are places that research can get to which perhaps other kinds of data can't.
Yes, indeed. And you can also, South London and Maudsley, for example, they won't be the only place that do this, but they have a programme where patients, service users themselves are actually not just involved in the research in terms of what the important questions are and priorities for them, but also they undertake the research. So there's a sort of patient and service user engagement right through the research journey, and that itself, I believe, brings some insights and credibility.
Yes.
That unless you are part of it, immersed in it, as you say, it just brings a different dimension which helps you triangulate things.
Yes. You've sort of long been a sort of champion of the patient voice, haven't you?
Very much so.
More recently about that in research, which is the work of Involve and others have been good at banging the drum.
Amongst other things, once the Strategic Health Authority is clustered with all the health and social care reforms, I've been supporting Professor Dame Sally Davis as the Chief Medical Officer for two things. One is acting as Senior Responsible Owner for establishing the new research regulator, the Health Research Authority, and I'm happy to talk about that a bit more if you want me to. But also importantly, I think, and in a way, for sustainability for the new health and social care system, really, really important, is acting as NHS research champion, drawing together my 35 years of experience and connections, understanding of the NHS and the wider system. But also, as you rightly say, using my personal passion for patient and public involvement throughout the clinical care journey, throughout research, throughout education and training of the workforce, throughout thinking around service change and configuration and so on. So as part, as owners, if you like, of the National Health Service. So one of the things which I'm really, really excited by is the decision by the National Institute of Health Research to appoint Simon de Negri, who of course is the chairman of Involve, as the director of public participation and engagement in research, to really support increasing patient participation, the sort of patient power, the pull by patients to be able to participate in trials, to have their say about priorities for the research questions.
Because some of the research proposals that I see come across the desk for sort of grant-giving programs is often, I think, seen as a kind of tick box, the PPI element. But I think the best research projects and research teams have really embraced the way, it's a bit like involving patients in service design, isn't it? That actually involvement at an early stage can help to make sure, first of all, that you focus on the right things.
Yes.
Which in research projects can be too, how you select your outcome measures, for instance.
Yes.
And how you measure sort of quality of life change. But also, more and more projects now are using are including service users as part of the research team, so they're involved in the kind of decisions about the framing of the research question, but also the execution of research.
That's right.
Access to perhaps patient groups might be helpful, and also testing out, the findings. Does this feel right? What does this mean?
That's right, and again, South London and the Maudsley, a great examples of that, including.
And mental health, I think, actually is in many ways sort of at the forefront.
I think so. Well, I think they've had a longer history of engaging service users across all of their activities, including recruiting staff.
The peer workers.
Yes, that's right. Advocates and so on. So I think they have a sort of more of a culture of that's the normal thing to do. But they've been involved, if I think of some of the things when I was speaking with them, in developing, as you say, what the patient-reported outcome measures should be.
Yes.
What are not just the questions, but how are they going to be measured and evaluated, as well as participating in undertaking the research. And I think it wouldn't work for everything, but I think we miss using the experts at our peril. Really. And if we think, it goes back to this whole engagement piece, doesn't it? Of staff, service users, of clinicians, and so on. You need the right mix in the room, and then you get the rich conversations, don't you? Respectful,
absolutely.
rich, challenging, myth busting. The assumptions that people make, and so on. So I think we've still got some way to go, but I'm feeling very optimistic about that becoming a much more normal way of looking at and doing things. Charities, of course, are doing some great things with that as well, research charities. So I know Asthma UK, for example, in helping them prioritise and make decisions about how to use their research monies, ran a very inclusive exercise with people who have asthma and their families, as well as academics and clinicians.
You were saying about how to get staff more research aware and research friendly. I mean, what do you think the answer is, in perhaps particularly in non-clinical staff? Is it journal clubs in hospitals for managers, or how can we make it easier for
things as these things always are? So it's demystifying research in a way, so that research, and I think the Health and Social Care Act helps with this, but so that research is seen as part of the, I like to think of it as part of the triple helix of providing service, of research and of education, so that it's talked about as much at boards, in team meetings, in your multidisciplinary meeting, in your handovers, in your patient discussions, as anything else is, so that it just becomes something else that is the normal part of the conversation. It's part of the patient experience, it's part of the clinical safety issues, it's part of evidence into practice. Well, how do you put evidence into practice unless you generated the evidence in the first place? How do you use evidence-based policy and practice to get evidence into practice? And so, amongst other things, particularly interested in how, with Health Education England now, one develops a more research-aware, research-literate workforce generally. So the NHS change model becoming increasingly the way in which people think about their daily work, about focusing around a common purpose, which might be improving a clinical service, it might be increasing participation in research trials, it might be in improving local government and primary care integration, pathways and so on. It almost doesn't matter, and you can use it big or small for transformation, but it is an evidence-based model to help people systematically work through how to actually achieve success.
The age-old tension is between a researcher saying, I can deliver a careful, mixed methods, 3-year evaluation, and a manager saying, that's too late, I need something now, I've got to, I need to know about disinvesting in inpatient eating disorders, what's the best evidence now? So there's that tension and that kind of what is good enough evidence, and I think where in clinical research, however difficult and contested it can be, there's a much more recognised way of synthesising evidence, much clearer hierarchy of evidence, and a way of systematising that knowledge. I think with sort of social science research, much messier, it's all very provisional, and context is so important. And I'm often torn because I want to sort of bang the drum for research and encourage people to look to research for some of the answers to some of these really tricky service problems, and yet knowing that it's very hard to point to single source documents or evidence syntheses that will really address, the issue for a manager now. And I'm thinking of, even the very best kind of syntheses like Martin Rowland and Bonnie Sibbald's work on shifting care out of hospital. It's a very sort of nuanced messages of these kinds of disinvestments may work in these circumstances, but may not produce the cost savings that you would expect.
Yes.
Whereas, for some particular things, I think, he was able to say fairly authoritatively, giving GPs direct access to diagnostic tests is probably going to be a good bet, both in terms of quality and cost. But on other things, it's much less clear, and I don't know what we do about it.
I mean, that's where sort of managerial, and by that I mean clinical managerial as well as general managerial and so on. It's where judgment comes in,
yes,
doesn't it? And
yes,
there's always the balance between pilotitis, which the NHS is incredibly good at, and everybody has to constantly evaluate everything for themselves rather than picking up something which is a good idea and just customising, adapting it. So there's the balance between pilotitis and not just picking up something and saying, okay, this is the Holy Grail,
yes,
because you do need to ask yourselves the right questions about your context, about your relationships, about your environment, about your baseline,
yes,
and so on. Because you just can't take anything for granted, and it's those sorts of judgments about what are the important things you have to look at to adapt, to localise, and what actually is just a red herring or an excuse. The not in my backyard excuse, it works there but it wouldn't work here because we're different and special. And that's where I think high quality leaders come into their own to create the sort of the environment within which people get together and ask those.
And also, as you were saying, sort of interpreting the results. I think what we're realising is that health services research is likely to be, partial, and it won't necessarily provide the exact answer to the exact question that you have in front of you, but there is still very useful learning.
That's right, and aren't those the sort of issues that managers at every level and in every profession and in every service have to face day in, day out, including individual patient encounters. Everything has to be just thought through and tailored and better done in discussion, whether it's between a clinician and a patient for their particular issue, or whether it's managers and their teams and other stakeholders and so on.
Yes, it's sort of shared decision making, isn't it, for the patient and clinician and for the wider organisation.
And getting a richer outcome because of that. And